Hello everyone. In this video session, I would like to discuss a very important question, that is squamous cell carcinoma of the oral cavity. This is a chapter that you will ignore the most. You won't read it usually. So I would like to discuss some of the few important questions like squamous cell carcinoma of the oral cavity, carotid body tumor, so-called paraganglioma, then salivary gland tumor, especially pleomorphic adenoma and Warthin's tumor. So these are the important questions that I would like to discuss. In this video, I would like to discuss the first part of this few questions. Before going to that, let us go for some of the important one-liner questions. Just remember, gingivitis. Okay, gingivitis means inflammation of the oral mucosa which surrounds the teeth, which is mainly because of accumulation of some dental plaque and calculus. What do you mean by periodontitis? Periodontitis, that means inflammatory process which affects the structures which support the teeth. That is inflammation of the periodontal ligaments, alveolar bone and cementum. The main causative organism is aggregative bacteria, also called actinobacillus. What do you mean by aphthous ulcer, also called canker sores? They are recurrent painful ulcer. The cause of it is not known in most of this, and there will be underlying neutrophilic, rich inflammatory infiltration, and it will usually resolve spontaneously. Okay. What do you mean by pyogenic granuloma? This is extremely important. So this is a picture of aphthous ulcer. Okay, you can see an erythematous halo surrounding an yellowish fibrinopurulent membrane. Okay, most of us would have got this condition. What do you mean by pyogenic granuloma? As you can see in this picture, you can see an erythematous and hemorrhagic exophytic mass which arise from the gingival mucosa. Remember, pyogenic granuloma is typically seen in pregnant women. It is also called as pregnancy tumor. Remember, it is a misnomer. It is not a benign or a malignant condition. It is just a proliferation of the fibrous tissue. Okay, fine. Once that is done, remember about HSV1 and HSV2. Herpes simplex virus 1 cause orofacial herpes, whereas HSV2 cause genital herpes. There will be red-rimmed painful ulcerations. On microscopy, we can see something called as an eosinophilic intranuclear multinucleated giant cells, and the characteristic and diagnostic test is called Sank smear test. Then coming into another important condition called oral candidiasis, also called as thrush, which is caused by Candida albicans in immunocompromised individuals. This oral candidiasis, which can be of different type, pseudomembranous, erythematous or hyperplastic type, mostly seen in severe neutropenia, chemotherapy-induced immunosuppression, chronic diabetes, prolonged steroid therapy and AIDS patient. Coming into what are the oral manifestations of systemic diseases, or so-called pre-malignant lesions of the oral cavity. That means if these conditions are present in future, they have a very high risk of getting transformed into malignancy. One such is called hairy leukoplakia. Just remember, it is caused by Epstein-Barr virus, and the characteristic location of this hairy leukoplakia is the lateral border of the tongue. Mainly in immunocompromised individuals, we can see a patches of fluffy, hairy, and this hair, it's not actually the real hair. It is nothing else but hyperkeratotic thickenings, almost located always on the lateral border of the tongue, caused by Epstein-Barr virus. Enough. Remember, oral hairy leukoplakia is not a pre-malignant condition. Okay, it's just an infectious condition caused by Epstein-Barr virus. What are the pre-malignant conditions or the pre-cancerous condition? That is called leukoplakia and erythroplakia. Okay, I'm just correcting my statement. I told you that leukoplakia, hairy leukoplakia is a pre-malignant. No, hairy leukoplakia is not a pre-malignant condition. It is the leukoplakia and erythroplakia. Both are called as the pre-malignant conditions. What do you mean by leukoplakia? Leuko means white. Okay, it is a white patch which cannot be scraped off, cannot be characterized clinically or pathologically as any other disease, is called as leukoplakia. This is a WHO definition. Sometimes, if it is reddish in color, we call it as erythroplakia. Okay, in this picture, you can see this reddish structure. This is actually called as erythroplakia, which is a reddish discoloration. Okay, fine. And remember, it indicates an underlying malignancy. Okay, they are pre-cancerous lesion. They are not cancerous lesion. They are not malignancy. They may predispose to malignancy in the near future. Sometimes there is an intermediate form in which we have both leuko and erythroplakia called as speckled leukoerythroplakia. So leukoplakia can occur any part of the body, any part of the oral cavity, and on histological examination we will see hyperkeratosis like our hairy leukoplakia. And erythroplakia again shows, and remember both are precancerous lesions, so they may have an underlying carcinoma in situ or a minimally invasive type of oral carcinoma. What is the most common carcinoma of the head and neck? The answer is always squamous cell carcinoma. Squamous cell carcinoma. It is the sixth head and neck squamous cell carcinoma. It's the sixth most common neoplasm in the world. Remember, head and neck cancer means tumors of the oral cavity, pharynx, larynx, and nasal cavities. What are the pathogenesis of the squamous cell carcinoma, which is usually multifactorial? The most common causative organism is infection with the high-risk human papilloma virus. What are the high-risk human papilloma virus? 16, 18, 33, 35, 51, 53, all this. Fine? Okay. And other causes are smoked tobacco and alcohol, actinic radiation and pipe smoking. Fine? Yes. And HPV infection. Remember, this oropharyngeal carcinoma or the squamous cell carcinoma of the oral cavity mainly involves the tonsils, base of the tongue and pharynx, and it mainly is caused by HPV 16 and 18. Out of that, if you want to choose one, you can go for HPV 16. HPV 16 is a better answer than HPV 18. Okay, fine, because we have references. Okay. And remember, this oral, so this is the leukoplakia. You can see, leukoplakia. You can see a whitish patch here. Okay, and histological appearance shows there is severe dysplasia, nuclear and cellular pleomorphism. Okay, but remember, there is no invasion of the basement membrane. The head and neck carcinoma, what exhibit a property called as field cancerization. What do you mean by field cancerization? Subsequently, in subsequent years, for example, this is the oral cavity. Okay, I'm just drawing a small picture here. This is the oral cavity. There will be a primary tumor. In subsequent, because of the subsequent exposure of the carcinogens like smoking and alcohol, in subsequent years there will be development of multiple tumors. That is called field cancerization. Very, very important question. Field cancerization is the feature which is exhibited by squamous cell carcinoma of the oral cavity. What is the molecular biology? You have to remember some genes. Okay, out of which the one is actually something called as mutations of TP53, CDKN2A and PIK37A, CA, Notch1 mutation, okay, and of course the pathogenesis of human papilloma virus, okay. All this, we have the human papilloma virus have two oncoprotein called E6 and E7. Remember, always E6 will bind to P53 and E7 will bind to retinoblastoma gene. Both are tumor suppressor gene that will be inhibited, so there will be proliferation. Fine? Yes. Coming into morphology, we can classify this squamous cell carcinoma into a keratinizing variant and a non-keratinizing variant. Keratinizing variant can be further classified into an early stage keratinizing squamous cell carcinoma and a late stage keratinizing squamous cell carcinoma. In early stage keratinizing squamous cell carcinoma, there is a raised form pearly plaques. There will be superimposed leukoplakia or erythroplakia, and in gross we can see induration and rolled out borders. Whereas, we can see there are conditions called as HPV associated squamous cell carcinoma and HPV non-associated squamous cell carcinoma. It's a very important table. Remember, HPV associated squamous cell carcinoma is seen in younger people, number of oral sex partners, the risk factors. It is a non-keratinizing variant, whereas one which is not associated with HPV, that is actually having a keratinizing variant. Poor outcome is the one. The squamous cell carcinoma associated with the human papilloma virus is always having very good prognosis. Don't think, HPV infection, so poor prognosis. No, HPV infection, good prognosis. Fine. So clinical outcome is poor in which has squamous cell carcinoma, which is not associated with the HPV. One if it is associated with HPV, the location will be oropharynx, or not associated will be in oral cavity. Remember, the one which is associated with HPV is a non-keratinizing variant, and one which is not associated with HPV is a keratinizing variant. So keratinizing squamous cell carcinoma actually always begin as a dysplastic lesions. They may be well differentiated, moderately differentiated, or poorly differentiated. And remember, as I have already told, HPV associated squamous cell carcinoma is characterized by non-keratinizing and basaloid cells. Don't forget this part. So this is with this I have completed the squamous cell carcinoma of the oral cavity. And just remember, then coming to the next questions. Cartagena syndrome. What are the characteristic features? Triad of Cartagena syndrome, you have to always remember. Okay, that is bronchiectasis, situs inversus, and recurrent sinusitis. This is the triad of Cartagena syndrome. Fine. Next, we have something called as nasopharyngeal angiofibroma, which is a benign tumor, okay, angiofibroma, okay, it is not fibrocarcinoma, it is fibroma, so highly vascular tumor, okay, which occurs mainly in the adolescent males, and the one mutation you have to remember is beta-catenin mutation. Then we have something called as Cnidarian papilloma. What do you mean by Cnidarian mucosa? Cnidarian mucosa is the mucosa which lines the nasal cavity and paranasal sinus. I think this has been asked as a MCQ question in your supply exam. Cnidarian mucosa lines paranasal sinus and the nasal cavity. Then olfactory neuroblastoma, that is the one which arises from the olfactory epithelium, which is a neuroectodermal type of tumor. It is also called esthesia neuroblastoma, which are actually a component of small round blue cell tumors like our Ewing sarcoma, neuroblastoma, nephroblastoma, retinoblastoma. Okay, and they are characterized present by rosette formation, and they stain positive for neuroendocrine markers like CD56, neuron specific anodase, chromogranin, and synaptophysin. And we have something called as midline carcinoma. Okay. Because it is mainly because of a mutation of a protein called NUT, which is the chromatin regulator. Okay, NUT chromatin regulator, and it mainly involves the midline structures. What are the midline structures of nasopharynx? Okay, thorax, midline structures of the thorax or the abdomen. Fine. Okay. And nasopharyngeal carcinoma is another important condition which is caused by Epstein-Barr virus infection. I have already told you, hairy leukoplakia is also caused by Epstein-Barr virus. Fine. And here comes a very, very important question called as laryngeal papillomatosis, which is a benign neoplasm which occurs in children. And this laryngeal papillomatosis is caused by what? Low risk human papillomavirus. What are the low risk human papillomavirus? Low risk HPV or HPV6 and HPV11. Okay, just remember this point. Fine. And rest of the things, that is a carotid body tumor, everything, I will be discussing in the next video. Okay, and with this I would like to end this video. So thank you.